leave the rejoin within. Please answer the if any by typing in the chat box. And please do not send requests for answers to the presenter. A few disclaimers. We have on May 9th, malignant lesions of breast by Dr. Consultant pathologist at Royal Government Hospital, Newport, UK. And on May 14th, we have approach to papillary lesions of the breast by Dr. Praveen Mahajan, who is a consultant histopathologist at SR Raheja, SRL Phalke, and Medical Center. So without any further delay, let's start. I request Dr. to share his screen.
Is my screen visible?
Yes, sir. Yes, sir.
I hope I'm audible.
Yes, sir.
Okay. Good evening to all of you. So right now, we will be starting on case discussions this evening. For the first 4 cases that I have, we'll be discussing those cases. Remember, the diagnosis is not important. I did not ask for the diagnosis anyway in many of these cases. Most of the cases. It's the way you think that is important. So without further ado, let us move to the first case. In the first case, this was a mastectomy received from a mastectomy with axillary dissection received from a 45-year-old female, who was reported as great carcinoma of no special type of biopsy. She has received 9 cycles of neoadjuvant chemotherapy, and on ultrasound, the size changed from 2 centimeters to 2 centimeters. On gross examination, the tumor bed was found to be 3.5 centimeters into 3.5 centimeters, and the other dimension was 3 centimeters. And on careful axillary nodal examination, we found 1 positive lymph node out of 15, with the maximum diameter of metastasis to be 3 millimeters. So, treat this as the representative picture of all the sections. Okay, so the first thing is to question that I asked was how to report this. How to report this case? Just imagine that this is the representative section from all the sections. This is one representative section. So, Dr. Jan, can you start? Good on.
Yes, sir. The first case, section examining shows predominantly fibrosis, admixed with inflammatory cells comprising of neutrophils, lymphocytes. These are scattered inflammatory cells comprising of neutrophils, lymphocytes, and probably a few eosinophils. To report it as it is a post-chemotherapy case, we will, according to KNM staging, we will report it as Y. T0 is because in ultrasound it is mentioned from 4 centimeter, it has come to 2 centimeter, but we don't know how much tumor is left over. So I still go with T0. N1A is because one node is positive, which is 3 centimeter, 3 mm, which comes in N1A, sir. That is 1, 2, 3.
We will go there later. I think you have, thank you very much. I think you've covered most of the points quite well. So, this sections predominantly, they show wavy loose collagen fibers. That's one of the characteristics of a tumor bed. There is histocytic infiltration. You can see the histocytes over here. The histocytic infiltration. There's capillary proliferation. Mild capillary proliferation or remnants of the capillary is possible. There are a few remnants of epithelial cells, but they're not the tumor cells. There's no residual tumor seen. So, however, there's lymph node metastasis. The question is, now, how do you know? Many of my residents asked me to do just wanted me to prove that it was collagen fibrosis. So we did the Werner hand lesion. Dr. Abhinay, can you just say what are can you describe this Werner hand lesion? I know this is out of syllabus, but still.
There are predominantly collagen bundles that are being stained in pink.
How do you know that they were collagen?
Based on the
color. Red in color.
Red in color.
My resident, when I pointed out when we were reporting this, she said that it was elastic fibers. So in order to do that, I wanted to differentiate between those two. There is this elastin, there is plain black. So this is the Werner hand lesion stain showing collagen over here. There was another thing. What are these?
Those histiocytic populations.
There is histiocytes. We did not think that it was tumor.
No, sir.
Yeah, good. My resident started arguing with me and asked me to prove it was a tumor. Sorry, it was a histiocyte. So there was fibrosis, capillary proliferation, lymphocytic infiltrate, other areas may show hyalinization. But she asked me to prove that it was a histiocyte and so on. And she got the CD163 done herself.
Nilothal, can you be a little louder? Can you be a little bit louder?
Okay.
Thank you.
Thank you. So these are histiocytes, CD163. There is histiocytic proliferation. So in the end, it is a pathologic partial response. Why is it a partial response? Dr. Anuja?
Sir, since we don't consider lymph node status in the complete pathological response, but since lymph node is positive.
Right. So Dr. Jan had gone over there. He already said that he considers that to be a partial response. That's a very important thing because many grading schemes don't include the lymph nodes.
Yes,
okay. But this is YPT0N1 MX, as he has already described that earlier. So this is a pathological partial response. The thing is, we are just going alongside and we are seeing how the response to therapy, how is that is reported. Either as no or minimal response, as a pathological partial response, in which we assess severity of the tumor in the tumor bed. How do we report it? We report if there is a pathological partial response, we report it in multiples of 10, from 10% to 90%. However, if the severity is less than 10%, we see whether it's closer to 1%, in that case, 1% or 5%. If there's a partial response, if we do find a tumor, we take at least 5 representative sections. But for pathological complete response, do you think, Dr. Anuja, could we take more sections or less?
Sir, more.
We should take more sections. Okay. For pathologically complete response, the lymph nodes must be negative, plus there should be no invasive tumor in tumor bed, and there should be thorough sampling. For this, we need more blocks, at least 1 section per centimeter per tumor or 10 blocks, which is very size. This is the recommended area. Often we cannot get up to that. The problem that we face over here is quite often we cannot find the remnant tumor. For that, we need the pre-chemotherapy radiology images that the tumor bed is difficult to identify. And many times, immunohistochemistry for CK, myopathy markers, and histocytic markers are helpful. Now, my question was how to report it. It was more of a discussion. What we know about response, because response, the reporting of response has to do a lot with prognosis. What we know over here, I just put forward two survival curves over here. Look at the yellow survival curve on top. This represents tumors which had no in situ remnant or invasive remnant, and for whom the lymph nodes were also negative. This blue line over here, they represented those tumors which had in situ disease, no invasive disease, but no nodal match. These were quite close together. But once there is even a single match, the survival goes down. That's why we should not be using exclusively for assessing response just for states like the Miller in which the lymph nodes are not assessed. However, even though DCIS is not associated with overall survival, it is associated with disease-free survival. Local recurrences are quite common, even if there is a remnant of DCIS. So DCIS should be reported. So pathological complete response is the most strongly correlated parameter for post-treatment survival. Assessment of lymph nodes is essential for prognostication, and presence of DCIS does not seem to affect overall survival, but leads to lower disease-free survival. Now, why is assessing the residual tumor cellularity important? Dr. Ramsey, can you please answer? Why is assessing? I told, see, over here, what we are getting is, if there is no residual tumor, that is very important. The partial response, all of them seem to have the same prognosis. In that case, why is assessing that? But we have already discussed to report the residual tumor cells, there is partial response in multiple subtypes. Why is that important?
That's the different maybe in complete response to the therapy. You can partially respond to the therapy, remnant tumor cells.
But the residual tumor cells, it allows us to assess the residual cancer burden. Why is that important? With the residual cancer burden, this is dependent on the percentage of invasive carcinoma remaining after chemotherapy, size of the tumor bed, and the size of metastatic carcinoma in the lymph nodes. It's a function of all three. It's a continuous score, but divided in 4 grades for easy prognostication. RCB0 means pathological complete response, P means pathological CR complete response, RCB1, RCB2, RCB3. And this can easily be calculated from residual cancer burden calculator on the MD Anderson website. And these are the 4 scores given. As you can see, the 4 scores, they have got widely differing survival rates. This RCB is closely related to prognosis. And in order to get this, you need to know the percentage score. That is why reporting the score is important.
Sir, I have a doubt.
Yes.
The last slide, it was written presence of DCIS seems to lower the something. I
Disease-free survival. It lowers the disease-free survival, but not the overall survival. Overall survival means death. Disease-free survival includes local recurrences as well as death.
The presence of DCIS.
Presence of DCIS as a remnant tumor increases the chances of local recurrence, but does not increase the chances of death. I mean, does not statistically significantly increase the chances of death. Okay, so that is why, for the purposes of this residual cancer burden calculator, DCIS is not that important. For the pathological complete response, many centers leave out DCIS, but whether you include that in your definition of complete response or not, you should be reporting that because it affects local recurrence. Okay.
Thank you, sir.
Now, this is the residual cancer burden calculator. As you see, what are the areas you need the 2 largest dimensions of the primary tumor bed. You have to calculate the overall cancer cellularity. Over here, overall cancer cellularity means in situ plus invasive, and then just percentage of cancer that is in situ disease. For the purpose of calculating what it does, from the overall cancer cellularity, it decreases the in situ disease. The calculation includes only invasive carcinoma behind the scenes. Besides that, you need to know how many lymph nodes you have and the diameter of the largest metastasis, and you can calculate it. But for all this, you need to assess the cellularity. And so, from the MD Anderson side, they have conveniently given a series of pictures by which you can calculate or assess the cellularity of this: 1%, 5%, 10%, 20%, 30%, 40%, 60%, etc. So that's that. But for assessing all that, you have to first identify the bed. What are the things which help you to identify the bed? Fibrosis and myelinization, capillary proliferation, lymphocytic infiltration. If you cannot find the bed, you see for these features, and then you can identify the bed over there. Now, we have just talked quite a bit about this. Let's see. Dr. Tanay, you are here? Dr. Tanay or Dr. PT?
Yes, sir.
Yes.
Okay. Can you assess the response? Anyone? Just take this as an appropriate setting. This is a different case. Can you assess this response?
So in this section show, we can see.
I have given you the side-by-side picture for that for your help.
So we can see a tumor which is in clusters and also in a form of a sheets, so that the tumor cells in this we can group it as a 10% group cells.
Okay.
So we will,
You think this resembles the 10%?
yes, sir.
Resembles the 10%. Okay.
Yes,
Dr.
sir.
Tanay?
Because one cell it will be 0.1% area. It will. So we will.
Okay. That's a valid. Dr. Tanay? You feel it's 25%. I'm sorry, I'm not getting what you were saying. Dr. Jain?
So I feel it is probably 2% disease of right.
10%. Dr. Rashida?
Sir, I think it's slightly more, 25 to 30% in grouped
Okay,
population.
good. The reason for why I gave all this was there's a lot of interobservable variability. You should be going and seeking what is the best area and the best thing over here.
Nilotpal, once again,
Yes,
please.
sir.
Throw can you be closer to the mic?
Okay, sir.
Like-
Is it audible now? Is it clear now?
It is audible, but it's a little feeble. Yeah, that's all. Otherwise, it's fine. A little bit.
Okay.
Yeah. Thank you.
Yeah. It it audible now?
Yeah, it's audible. Yeah.
So, thing is, there's a lot of interobserable variability over here, but overall, the commonest answer we got was around 10%. But the thing is, that's why you have to see plenty of slides, you have to have multiple sampling, and access as many slides as possible. So, in that case, now let's go back to our case. This was the case. It had, it was a full response in the breast. Let us try to calculate the residual cancer burden of our case. Now, what was the primary tumor bed area? It was 35 mm into 35 mm, right, from the history. What was the overall cancer cellularity?
0%.
0%. The percentage of cancer that was in situ disease, that was also 0. There was one positive lymph node, and the diameter of the largest metastasis was 3. Then calculate it, we get a RCB of 1. That is the residual cancer burden of 1.205. If you remember the survival graph that we saw, the prognosis is not as good as that of the complete response, but it is certainly better than the RCB2 or RCB3. It's somewhat of an intermediate prognosis over here. So that's it. This is finally, it's a pathologic partial response, RCB1. But in order to calculate and get the complete prognostic information, the type of response in both breast and lymph node should be reported. There are quite a few systems over here which are commonly used, which use only the breast system, which use only the response in the breast. No, in both it should be reported. Number 2 is representative section should be taken from the tumor bed, at least 5 in partial or in no response, and 1 per centimeter on at least 10 in complete response. Because there is a lot of interobservable variability. You need as many sections as you can so that once you get the average similarity will come more or less the same. In case you have a partial response, the similarity of the bed should be reported on. In multiples of 10, if the similarity is less than 10%, then 1% or 5%. DCIS should be reported separately. And the number of lymph nodes involved and the data dimension of the lymph node, that should be reported. These are the minimum things which should be reported in any post-chemotherapy breast in order to prognosticate and further treat the patient. So this is the reason this case was given. Now, is it clear? Any questions? Yes, please.
Sir, as you told, sir, if lymph nodes, sir, we do receive many post-NSCT cases, sir. In most of the times, sir, the lymph nodes will be negative, sir. In that, only we give a Milner rating, sir. Are we supposed to report even RCB in that, sir, even if the lymph node is negative?
We don't report the RCB. We give enough information so that the treating oncologist reports the RCB.
Okay. So we should not include that in our report, sir, because we
No. Unless the surgeon or the oncologist asks it, what is the need? But we should be including sufficient information for them to calculate the RCB. We should know why we are reporting this. So it's the complete information. And many times we don't get any lymph nodes because the lymph nodes are fibrotic. Even those fibrotic foci should be reported as relative lymph nodes, completely exhausted. Got it?
Right, sir.
And that is negative. Okay.
Right, sir.
Any other questions?
So, the tumor bed calculation on gross examination,
Yes.
it can be from one site only or multiple sites. Like, just had a doubt about this tumor bed.
Tumor bed, it depends on the focality of the tumor. For staging, what do you take? For the purpose, see, tumor of the bed, it depends on the focality. There may be multiple tumors.
Okay, so should we add them?
For staging, in staging, what is the thing that you do? You add up the tumors or you take the largest dimension for the purpose of staging? Yes. It's the same thing over here. Okay.
Yes.
Mind you, for the purposes of residual, you should be reporting the dimensions of the separate tumor also. Because the separate tumor beds, if you want to calculate the residual cancer burden, the separate tumor beds, the tumor content in them adds up to the burden. I'm telling you, because you asked about staging, that is why for staging you take one, the largest. But if you have to calculate for the residual cancer burden, you have to report the different tumor beds that you get separately. So it's a total tumor bed and the average similarity of the total tumor bed in order to give the prognostic information. Okay?
Okay. Yes.
So, will we proceed to our next case? Next case. This was assessment of IHC. This was a patient of a 64-year-old core biopsy breast. This treated as a representative section. The question that I asked was not the type, because I'll be asking the description. But what is the expected estrogen receptor expression? What is the expected ER expression in this case?
Positive.
Okay.
So it will be
Okay.
positive.
It will be positive. Of course. Good, but I'm not saying yes or no. I'll be asking you. So let us first decide. Because in order to call it positive or negative, first we have to know what the tumor is, right? Only then you can proceed. Got it? So, can you please do the honors? Can you describe this? Dr. Vaishnavi, right? Dr. Preeti, can you please, Dr. Preeti,
Yes, sir.
can you please describe it?
So in the second section shows a tumor cell having round to oval, having slightly pleomorphic nuclei with a prominent nucleoli and abundant amount of eosinophilic cytoplasm. In this section, we can also see a stromal periductal elastosis.
Okay. Anyone wants to add anything? Dr. Tanay?
The tumor is in a tubular formation, sir.
Okay. Dr. Vaishnavi? Thank you very much. Dr. Vaishnavi? Okay. Okay. Dr. Harshita,
Nothing to add.
can you describe?
Sir, tubular morphology. The tumor cells are distributed in tubular pattern.
Dr. Jain?
So, section examine shows tumor cells arranged in tubules, sir, in a background of fibrous stroma. These tubules show round, angulated with open lumen, lined by single layer of epithelial cells. Mitosis is minimal, sir. Next, I'd like to see the
So, let's see. mostly. You're seeing the breast epithelial cells forming predominantly tubules. Tubules are angulated. You can see the angulation over here. That's very important. Those angulations may be due to the first thing you see in breast is once you see them, you check out for the myepithelial cells. The myepithelial cells are absent. So it's a single cell pattern. That's the one thing you have to say. You don't see myepithelial cells around these. However, the size of the nuclei is not very much increased. I did not have the larger picture. The mitotic count is, I did not do the high part picture, but the mitotic count is also not increased too much. This mark, that's what we see here. Mitotic count was low in this case. So this is a grade 1 carcinoma. Mostly they form tubules, greater than 75% of the cases. Tubule score 1, nucleus score, I felt it was 2. My residents did not feel so, they felt it was 1. And mitotic score of 1. So grade 1 carcinoma. Anything you want to add, Dr. Jain?
That's all, sir. These are the main points, sir. Sir.
Okay, do you want to put any special type to it?
Sir, first of all, sir, as you already told, the myopathy cells are absent, sir. I feel so, but still to confirm it, I do P63 and confirm it.
Okay, the P60
To rule out the adenosystic carcinoma, sir. It's because the ER expression is different in both, sir.
Right. Good. So you have two differential diagnoses depending on that. Right. These are blood vessels. There is fibrinoid necrosis in the blood vessels. It's not necrosis of the. It's not necrosis of the tumor. There's fibrinoid change in the blood vessels. So that's that. It's possibly a tubular carcinoma. I'll tell you. It was the myepithelial cells were absent over here, and since the myepithelial cells were absent, we call it a tubular carcinoma. And but we can definitely give the diagnosis only on complete excision. Core biopsies, there may be other areas which have NST-like features. We can definitely say that it's tubular only on complete excision. Now, but the question was not about the type. It was about what is the ER expression and why is that important? These are the essential IC markers. ER, PR, HER2. ER and HER2 are the predictive markers. Dr. Anuja, what are predictive markers?
Sir, pardon?
What are the predictive markers for therapy?
Sir, ERPR are the validated markers in the prognosis.
The predictive markers are those which are useful for starting therapy, on the basis of which a systematic therapy starts. For example, on the basis of the ER staining, you give anti-estrogens. On the basis of HER2 staining, you give trastuzumab. So those markers on which basis of which it predicts therapy, response to therapy, those are predictive markers. ER is right now considered more of a prognostic marker than a predictive marker. Okay, but since ER and HER2 are predictive markers, they need careful quality control for best results. All IC needs careful quality control for best results. So for the interpretation of IC, can you just, this is a separate portion of the breast score for ER. Can you guess what this is? Okay, let me tell since I have not given this. These are the normal lobular structures. And why are they important is they serve as internal controls. How do you know that the IC for ER is work? You look for normal controls. Look for normally in the areas with no staining. You see over here, ER has taken up stains over here. So you look for these normal areas. These internal controls are very important. Sometimes you do not find internal controls. You have to do with external controls. And the controls should express the IC. For ER is a special case. There is a low positive ER between 1 to 10%. You should be adding tissues as normal controls which show low positivity. For example, tonsil. In addition to cervix, which serves as a normal control. The IC has to be validated very well, and you need morphological correlation. Morphological correlation is very important for finding false negative results. So, what do we know about morphological correlation in breast cancers? We do know that ER and PR staining is associated with certain types and patterns in breast cancers. Tubular carcinoma, fibriform carcinoma, mucinous carcinoma, they are quite often ER-PR positive. The conventional lobular carcinoma, ER-PR positive. Most NST cancers showing even partial tubular or lobular differentiation, they show ER or PR staining. Quite logically, since ER and PR, they are associated or co-expressed with the luminal genes, which are responsible for formation of the lumens, the tubular structures over there. HER2 staining is seen in high-grade breast cancers, especially in certain special subtypes like apocrine differentiation, 2/3 of apocrine carcinomas or apocrine subtype of NST, around 1/3 of pleomorphic lobular carcinomas, glycogen-rich clear cell carcinomas, lipid-rich clear cell carcinomas. So knowing about the pattern makes you expect that you are going to get the stain, and that is important in order to rule out false false negatives. If you get plenty of tubules, and yet you find that it's ER negative, either your diagnosis is wrong or your processing is wrong. Repeat the same. That is why it's important. Remember, these are associated patterns only, not a hard and fast rule, but these are important for finding false negative ICs. Knowing these, what type of PR staining do you expect? Dr. Vaishnavi? Okay, Dr. Anuja, you came over here. You said. So what type of PR staining do you expect?
Sir, positive one.
Huh?
Here, high dysplastic reaction is there.
So?
So it is associated many times with ER positive ones.
There are plenty of tubule formation over here.
Sir, tubular carcinoma can be.
Plenty of tubules over here. You expect
Strongly positive.
ER positivity. If this did not show ER positivity, you should have repeated the stain or got it stained on a second block. That is the importance of morphological correlation. Let's go to a next case. For this, Dr. Abhinay.
Yes, sir.
Abhinay Sundari.
Yes, sir.
Okay, tell me. For this case, can you predict the ER staining?
Actually, they are singly arranged, sir. And
Yes.
if talking about a lobular carcinoma at all, it should be conventional, should be ER positive. And,
Good. Good. Very
Yeah.
good. So, if you know the pattern, many times you can predict the ER. Okay, so that's that. So, validation of IC is a very, very important thing, of which morphological correlation is quite needed. People, many times I've seen people not paying attention to the morphological correlation, as a result of which they miss out the false negatives. But at the same time, we should know about validation of IC. For validation of IC, we should be, how we just, before starting a test, we should be testing on 20 positive cases and 20 negative cases. Before starting any predictive marker for use. 40 cases you need to test IC for and get a 90% concordance. That's what cases are needed. What a predictive marker. What a a diagnostic marker. Now, predictive marker, ER, HER2, those needed for prediction of frequency. P63, CD163, these are diagnostic markers. For them, it is slightly lower. You need just 20 cases, 10 positive cases, 10 negative cases. You should stain at all staining intensities, and initially, at the time of getting the reagents, you should be getting at least 90% concordance. Earlier for ER and HER2, people thought of 95%, but now the recommendation is about 90% concordance. Okay, and if this is the minimum quality, you should attempt for both for positive cases as well as negative cases. You often get new lots. The new lots must be checked by at least 2 positive and 2 negative controls whenever your reagents, the lot number changes. For a predictive marker and for diagnostic marker, you need 1 positive and 1 negative control. But if you change the clone or if you change the processing, for example, a new fixative or a new dehydrating agent, clearing agent, that requires revalidation. Again, start with 20 positive cases and 20 negative cases for a predictive marker, or 10 positive cases and negative cases for a negative marker. Overall, for the quality of the IC stain, you need good validation, proper controls, both internal and external, and morphological correlation. With this, so state the importance of morphological correlation, we move forward to case 3. Okay, so this was case 3. Since you are here, Dr. Vinay,
Yes, sir.
what I wanted is, this was a core biopsy, okay, in the woman in her 40s. Okay,
Yes, sir. The section.
and can you please describe it?
Yes, sir. The section studied shows HLE slide shows low to intermediate grade DCIS with monotonous population with moderate pleomorphism. There is presence of central necrosis. Pattern is scriptiform pattern, sir. Surrounding showing desmoplastic and lymphocytes are present, sir. Lymphocytic response is present, sir. And there is an intact myoepithelial layer that can be seen, sir.
You can see the layer of my epithelial layer.
Yes, sir.
Now, these are the P63 stain. What does it show? Dr. Ramji, why was the P63 stain done over here? Dr. Ramji, I don't think he's here. Dr. Vaishnavi, why do you think P63 stain was done? Dr. Vaishnavi, can you hear me? Am I audible now, or has my voice gone down again?
You're audible, sir.
Why do you think we have done the P63 over here?
To highlight the myoepithelial cells that are present, sir.
Right, and why is that important?
The presence of myoepithelial cell is the distinguishing factor between an infiltrative and in situ carcinoma.
And now, this is a HER2 stain.
Yes, sir.
Dr. Jain,
So,
can you do the honors? Just a state.
yes, sir, it is 3 plus according to ASCO. So 3 plus is complete circumferential membrane staining more than 10%.
Okay. Now, my question was, report the IC status in this patient. IC status of HER2. What will you report?
So, I will report it as positive 3 plus staining. So, I
You will
will
report positive. Dr. PC?
Yes, sir. Sir, I will
What
report it as
will
a sir, I will report it as a HER2 plus because there is circumferential intense complete means in more than 10% of the tumor cell
So that's why you will report this
as a
as a
HER2
positive tumor.
yes, a HER2 positive 3 plus.
Okay.
Sir,
And Dr. Ravindra?
yes, sir.
Also HER2 enhanced.
Huh?
HER2 enhanced.
HER2 enhanced.
Sir,
What
my
do you mean by HER2 enhanced?
there is over amplification.
Okay, let's proceed. Let's proceed over here. Dr. Archita, do you have any comments regarding this?
Sir, if I may.
Okay.
Sir, if I may. There is complete membranous staining, sir, but there is also staining of the cytoplasm. Whether this is
There is complete membranous staining. Okay.
there is complete. Okay, sir.
So show the ductal lobular unit with the column of epithelial cells completely clean the duct. The cells show cribriform as well as solid architecture in cases. Central choroidal P63 stain shows the myepithelial cells completely encircling the cells. No evidence of breach. Cells show intense complete membranous staining for HER2. Now, you all of you know this is how HER2 is assessed. Circumferential intense staining in greater than 10% of tumor cells is IC3+, which is supposed to be positive. Weak to moderate complete membrane staining observed in greater than 10% tumor cells, it is IC2+, equivocal. You should be either repeating it or going for ICH. Incomplete staining that is stained, incomplete staining that is IC1+, or no staining or membrane staining that is barely perceptible in less than 10% of tumor cells, that is IC negative. So that is IC3+ staining in the cells. And this is DCIS. The question was, again, report the status of HER2. The thing is, HER2, remember this, you just made a diagnosis of DCIS. HER2 staining as a predictive marker is recommended only for invasive carcinoma of the breast. You should not be reporting this HER2 as a predictive marker at all. Got it? So, over here, HER2, leave it out. You can add a comment to the report. HER2 report not given since it's not recommended as a predictive marker. There's a caveat to that statement, mind you. I'll come to that. HER2 in the state should not be reported as a predictive marker as per present guidelines. That's why morphological correlation and thinking how your report. I got a question. Should we not search for invasive focus? That is why I gave the P63. We were searching for the invasive focus right throughout. Only after a careful search in invasive focus, and in those areas, in those invasive areas, should we get that a report of HER2 possibility. But if it is pure DCIS, no, not as a predictive marker. Mind my question over here, not as a predictive marker. In DCIS, ER is the only recommended predictive biomarker for routine testing. HER2, when the HER2 is positive in more than half of the high-grade DCIS, but once they become invasive, the percentage of HER2 positivity goes down. And it is not recommended to test as a predictive biomarker. But I've already told you, there's a caveat to it. Recent studies have found that HER2 expression may be correlated with recurrence. So in the future, the recommendation may change, but not as a predictive biomarker, but as a prognostic biomarker. So that's not for starting treatment. Even that you have to say. Because once you give HER2 positive as a predictive biomarker, you are basically telling them, start trastuzumab. Start the treatment worth around 15 lakh rupees in the Indian setting. KH67 is also associated with recurrence. So there's a lot of differences between ER and HER2 testing. You say that ER is nuclear, HER2 is membranous. You say that ER can be seen only in the primary tumor. HER2, you can do the testing either on the primary tumor or on secondaries, axillary lymph nodes, even on cell blocks from pleural fluids, metastasis. Anywhere you can do HER2. In the DCIS, ER testing is recommended. because anti-estrogens lower the local recurrence rate after DCIS. In HER2 testing is not recommended. For ER, the type of test is likely only for HER2, it may be IC or in situ hybridization. It's not only FISH, CISH is also there. Ideally, it could be IC or FISH, any of these tests can be done for HER2. So that's that. So finally, the takeaway point from case 2 and 3 is morphological correlation is essential for reporting IC. Without that, you cannot just blindly report that. Is it clear? Any questions? Any questions from anyone? Okay. Yes, please. Dr. Tanan, your voice is breaking up a bit. That's why I'm having trouble hearing you.
You get it?
Can you just type it? I'm having difficulty following you.
So I also have the same doubt, like
Yes.
the expression of ERPR in case of tubular carcinoma and DCIS, like how it will change the prediction or prognosis.
ER,
both-
ER. See, basically, I'm calling it ER positive. See, in tubular carcinoma, whatever the grade of the carcinoma, once it is ER positive, you have to give anti-estrogen. That improves the prognosis. Chemotherapy can be avoided in tubular carcinoma since it's low grade, low microtic count, not anti-estrogen therapy. It helps in survival. In the case of tubular carcinoma, it shows a mild improvement in the overall survival, even for tubular carcinoma, even though that's a low Nottingham prognostic index tumor. For DCIS, that brings down anti-estrogens, bring down local recurrence. These are what are the results of multiple trials. Anti-estrogens are not that toxic. That is why for anti-estrogens, you need to do ER. Chemotherapy is more toxic. Whether you can avoid chemotherapy or not is a question. Got it? So, what was your question? How will it help ER in case of tubular carcinoma? In the case of DCIS, it will help in bringing down the local recurrence. For tubular carcinoma, it will increase the progression-free survival. These are the findings of trials. Overall survival on age-based trials, not too much. Progression-free survival, yes. Anti-estrogens, even in case of tubular carcinoma, they do help. Is that clear? Or was that the question? Or did I misunderstand the question? I'm not getting this. Did I misunderstand the question over here?
I think that was fine, sir. Can go ahead.
Okay, good. So case 4 is different. Over here, this was a 25-year-old female who came with a breast mass with a Dr. Bhishma, is the audio quality good, better now? So this was a 25-year-old female, breast mass, full biopsy. Okay, we gave the HID section. Right, I'll just do one thing. Just a minute. I'll try to see what can be done about this. Is it better now?
Yes.
That's fine.
Yeah, much better than before.
Yeah.
Yes.
Good. Now, were my previous things totally unaudible? Should I go over that again?
No, they were fine. We could hear you. Only thing is your voice is much sharper and louder now. Otherwise, also it was fine.
Okay. So this is a 25-year-old female who had a breast mass with a full biopsy over here. These were the HNE images. I had given the IC stain for HER2 and for ER. The question was, what further tests should be done to aid in treatment? So, can we, Dr. Harshita, can we just proceed? Can you proceed with the description over here?
The section studied show sheets and singly lying cells. So we can go for P63 to see the myoepithelial cells, since it is a young female, to differentiate whether it is towards a benign entity or a malignant entity. And
Okay, you want the P63 stain in this case. You have doubts about its malignancy.
so to confirm that it is a benign, to see the myoepithelial cells.
Okay. Dr. Preeti?
Yes, sir.
Can you please?
Should I describe the slide?
Huh?
Sir, in the section shows a tumor composed of a disc cohesive round to oval cell having a round and notch ovite nuclei with scant cytoplasm. And sir, it is arranged in Indian pile pattern. Sir, we can see, sir, at places it is arranged in sheets. And the stroma show infiltration by mononuclear cell. So we can see the hyalinized stroma showing infiltration by mononuclear cells.
Mononuclear cells, meaning?
Sir, lymphocytes.
You were seeing lymphocytes.
So slightly here we can see the hyalinized stroma. So the test we will do it is the next test we will perform it is the E-cadherin for lobular carcinoma. Yes, sir. For invasive lobular carcinoma to differentiate it from.
For invasive lobular carcinoma.
Yes, sir.
Dr. Anuja, I have seen quite a few things over here going for the types they want to ER. Can you want to describe it? Dr. Anuja?
Yes, sir. Sir, it is
Yes.
a slide showing mostly singly lying Indian file pattern and also the shared.
Okay. First thing is, I'm seeing singly line. I'm very sorry to disturb you. I've just seen the time right now. I'm seeing that the time is passing by. I'm very sorry over here. That's why I'm going a little faster now. See, they're singly lying epithelial cells. And by the side of that, I don't see a second layer of cells. Okay, there are quads of cells. Epithelial cells arranged in quads and nests, haphazardly infiltrating through an basal tumor. I did not think of asking for a myepithelial cell marker over here, even though later on maybe I could have asked for it, but I thought that it was epithelial over here. That did not come to my mind at all. The stroma was desmoplastic. The nuclei showed marked enlargement and pleomorphism. However, that was not the question. It was a grade 3 breast carcinoma, but there was not much lymphocytic infiltration. Thing was, it was both ER and HER2 were negative over here. Right? You agree, Dr. Jain?
Yes, sir.
ER and HER2 were negative.
Yes, sir.
So-
PR and negative.
We found the PR also to be negative. So it was a triple negative breast carcinoma. Okay, triple negative breast carcinoma. Question was not whether it was a triple negative breast carcinoma or not. We did a repeat testing because that's a standard practice. You do a repeat testing on another block. That also showed any biomarker. What next for treatment? The question over here was, what should you do to aid in treatment? What further tests should be done to aid in treatment? Anyone? That was the question.
Yes.
PDL1. I got an answer as PDL1 from Dr. Aisha. Okay. Besides that, Dr. Jain,
So KI67 and PDL1 are the two markers which I'm going to do.
Ki67, PDL1.
So KI67 to see the tumor grades, like it is already it is negative, triple negative, sir.
See, it's a high grade tumor.
So,
You have chemotherapy as it is. How is Ki67 going to add?
and also the okay.
Someone has called E-cadherin over here. Why? How is E-cadherin going to aid in treatment? Mutation for CEC1. RAS mutation. Dr. Tanay, RAS mutation. BRCA1 is, someone has said BRCA1 is done in ER positive. What was it? I just went off.
Yeah, Tanay also said BRCA, sir. Yeah, CM1, what I could hear.
Tanay also said BRCA.
Yes.
Good. And someone said that BRCA is done in ER positive. Now, let's see what are the biomarkers which are recommended in androgen receptors. Go on.
GATA3 can be.
Huh?
GATA3, CATA3, sir.
CA?
GATA3.
GATA3. GATA3 is more advanced.
Sir, can we do GCF15?
Can you do CK56 and EGFR?
EGFR. Okay, interesting things. But let's see. Let's see what the biomarkers in triple negative breast cancer are. PDL1. Quite a few people said PDL1. But remember, PDL1 is negative. This tumor did not have much of a-
Dr. Vaishnavi, please mute yourself.
Okay.
You can
So,
continue, sir.
androgen receptors, good. Not fully recommended as yet. But yes, for in triple negative breast cancer, that is done. Third one is BRCA1, BRCA2. Quite a few people got it. But BRCA1, BRCA2, what type of testing? You do germline testing over here. There are two types of testing, germline and somatic. You do germline testing. It's important because it tests the other family members at risk, as well as it's an indication for starting therapy, olaparib or other fast inhibitor therapy. So it's a predictive biomarker as well. It's quite helpful. In this case, the surgeon asked me for the advice. I said, the PDL1 may have a result. It was less likely to get over BRCA1, BRCA2. We did that, and we got this result. Okay, this result over here, red line. These are the mutations. I know this is out of syllabus, but can anyone say what these mutations are? Dr. Preeti, you want to try?
So I don't know.
Okay, Ramji, Harshita. Okay, let's see. It's quite intimidating, right? Don't worry about that because it is not the question put. Thing is, I wanted to put it to show something else over here. A gene is made up of many nucleotides. What this means, you see this, and BRCA1, BRCA2 testing that has got plenty of nucleotides. It's a protein which is more than 2,000 amino acids long. So at the position for the nucleotide position 928, cytosine has been replaced by thymine, which gives to this mutation in the amino acids. At the 310th amino acid, glycine has been terminated. TER means terminated. It's a nonsense mutation. It's a 2,000 amino acid long protein which has been terminated at the 310th amino acid itself. So since it's a much shorter amino acid, what sort of mutation should it be? Should there be a loss of function? Yes or no? What does common sense say, Dr. Preeti? What I'm telling you, understand what I'm saying that this amino acid, the normal amino acid is 2,000 amino acids long. Over here, this has got terminated, stopped after 310 amino acids. Instead of 2,000 amino acids, you're getting a protein which is only 310 amino acids long. Is it likely to be pathogenic? Well, this is a form of mutation. It's a nonsense mutation. It's a loss of function mutation. There's also the EF. But if you don't understand this, don't worry. Thing is, you know this. Most of us, when we go over there, we make a search for it. Have these mutations been found elsewhere? Have these mutations by experts, have they been found? Make a list. And then we search for it in recommended databases. Or one of them is ClinVar. And this mutation on the top, this was found to be pathogenic when reviewed by an expert panel. Pathogenic, is there any other type of mutation? The next mutation that we got, that was classified as benign. So all mutations are not disease causing. There are pathogenic. My point over here was to tell you that there are pathogenic mutations as well as benign changes. You get any mutations does not mean that is disease causing. You should properly investigate that further. That's the first thing. Okay. Next very interesting thing that is you should look at is the VF, variant allele fraction, 49.5. This just means what percentage of the DNA which was sequenced, what percentage of the DNA had this mutation. So over here around 50%, 49.5% of the DNA has the mutation. So, for BRCA1 and 2 NGS, variants may be classified as benign, likely benign. These are the way you get your reports. Uncertain significance, likely pathogenic, pathogenic. All these, pathogenic and likely pathogenic. Pathogenic is the one which is important for treatment. Some oncologists consider likely pathogenic as well. The others are not. And bioinformatic analysis needs to be done regarding that. It's based on known or predictive action of mutant protein. There are two types of testing. Germline testing for carrier or disease status, as inherited since birth, which is done on blood or saliva, or somatic testing, which is done for mutation in the tumor itself. It is done on tumor cells from biopsy or cytology. And we need to know the variant allele frequency and the depth of sequencing. But variant allele frequency is what percentage of DNA reads through the variant. In our case, 49.78%, 49.58%, actually, this is a typo, 49.58% of the variant allele frequency for a pathogenic variant. What does this mean? This means that around half of the DNA reads had this variant, right? So, Dr. Jain, once you have this information, this is for the germline testing. So, can you elaborate further? Dr. Preeti? No, it's not homozygous. It's compatible around half of the DNA reads. That means in us, in every cell, we have two alleles. Half of those, half of the DNA has this is compatible with one allele out of two having the variant. This, for an autosomal recessive condition, is suggestive of carriers. It's a carrier for the mutation. This shows higher predisposition for cancer at an younger age. This lady was only 25 years of age when she had this cancer. She's also susceptible to ovarian cancer. Other family members may also be susceptible and may respond to PARP inhibitors like olaparib. So this was the final diagnosis in this case, BRCA-associated breast cancer carcinoma. And over here, maybe she's a candidate for PARP therapy, which, by the way, is a stronger therapy than immunotherapy. So let us, at the end of it, let us just summarize the entire thing. What are the molecular tests indicated in breast carcinoma? I consider, okay, morphological diagnosis. Morphological diagnosis, breast carcinoma, grade 3. What else is needed for treatment? It's triple negative cancer. Finally, we should be thinking like doctors. Okay, in this case, you should be knowing enough to know what test to give, what test to diagnose, how to advise the surgeon, how to act like a doctor instead of just giving a report type, which is important. Mind you, morphology is the bedrock of pathology. But at that time, we should be also going beyond morphology and doing our role as doctors over here, advising the proper test, trying to interpret that using your knowledge of pathology. So over here, the thing was not about the diagnosis. Okay, this was an NSP thing. I don't think this was lobular carcinoma because there were too many nests. But whether it was lobular or NSP does not matter. How to change the treatment? That is what matters, right? So, what are the molecular tests indicated in this carcinoma? I consider IHC also to be a molecular test. PRPR, leutomia, Ki67, PDL1, androgen receptors are coming up. So, finally, I don't think they have been recommended as yet. For HER2, at NGS, germline testing for BETA1, BETA2. Okay, and for somatic testing, it is done in a separate setting. For ASR1, which is ASR1 gene and PIK3CA mutation, for someone getting anti-estrogens, within 3 or 4 years, many of them develop resistance. Many of them have local recurrence. To test for resistance to anti-estrogens, you need to do the mutational profile in ER-positive tumors having anti-estrogens for ASR and PIK3CA. So these are the molecular tests indicated in this carcinoma. Any other questions over here? So, I conclude that. Huh? Ramji?
Yes, sir.
Any questions?
No, sir.
So finally, over here right now, we dealt with 4 different case scenarios. One, for prognostication, knowing how to actually assess the residual tumor, how to report it completely. Number 2, for ER and HER2, the importance of morphology. Number 3, the importance of molecular testing and when to check it out. So that was the philosophy. Any other questions over here? Okay. Thank you.
Thank you.
Thank you.
So you can stop sharing your screen, then I'll share mine and we'll continue with the rest of the cases.
Right. I've stopped it. Okay. Let's stop my video also. Thank you.
So can you see my screen now?
Yes, sir.
Right. So we have gone off discussing about instances of essentially mainly centered around breast carcinoma, but we covered a spectrum of how important glossing is in certain scenarios. How do you correlate morphology with IHC and what care do you take when you are trying to interpret IHC and give out a report? Right. So IHC is always given. It has been repeated many times over in this platform that IHC is always given a report in a context. So many of these cases you might be wondering what has it got to do with exam, right? So exam histopathology, though even we mostly focus mostly on the slide aspect of it, histopath is you encounter questions of histopath in several stations in a during your exam, right? And glossing station is an important aspect of it, right? And a lot of the other IHC interpretations and your fish interpretation and even sometimes molecular test aspects of it, you can get questions on it in your OSCE stations, right? And especially because most of the centers, you get to see a lot of breast carcinoma cases and interpret ER quite frequently. Some examiners can bring and give you a case where you have to interpret the HNE and interpret the IHC also as a major case, right? So that was the point why we took a set of 4 breast cases and discussed these issues around it, so that similar principles also apply in other organs. For example, certain organs like your colon and larynx, glossing is very important. Like larynx, if you need to be able to identify all the subsites, identify where the tumor is involving, so as to be able to stage it appropriately. Colon, especially the left distal colon, so rectum and sigma, the tumors involving there, you need to know how to appropriately gloss them, which area you have to get. You need to identify the peritoneal reflection. So there also those kind of questions you do get asked in exam. So for histopathology exam preparation, don't just focus on looking at slides and looking at a huge variety of slides, right? Histopath and the ancillary testing is also an important component of the exam. Right. So with that, let's move ahead with case number 5. So can we have Abhinaya? Can you just present this case?
Yes, sir. The 55-year-old male with a history of loose tooth extraction 2 months ago presented with epistaxis. CT shows a radiolucent lesion involving the buccal bone, palatal bone, extending the midline and the right maxillary sinus. Incision biopsy is done from the alveolar region. Here, the histopathology slides are showing. I'll just go ahead, sir. The slide is not being shown there.
Sure. I'll just put it up. Yeah. Can you see that now?
Yes, I can see that. So there is the section shows it is a diffuse lesion, sir. There is a stratified squamous epithelium that is present. Underneath the subepithelium is showing diffuse, and just beneath the epithelium there is a nodular form of infiltration that is present. And on a low power, it looks like sheets of round blue cells. On a high power, which again it is a diffuse pattern, sir. And there are pleomorphic cells with mitotic activities present, sir. And the pleomorphic cells are large cells with a prominent eosinophilic macronucleoli is present. There is a moderate amount of eosinophilic cytoplasm in a sort of feathery pattern is there, sir. Okay. And mitotic activity, I could count 2 to 3 per field in which it was given. Okay. And other than that, I'm not seeing much of other things. Based on this, I had a differential of there is no pigmentation, so I thought a melanophytic melanoma is a possibility.
Good. Good.
And a round blue cell did come into differential, but because of the macronucleoli, eosinophilic nucleoli, that was ruled out, sir.
Right. And any other thing which goes against round blue cell tumor? You describe how did you describe the cytoplasm as?
It's moderate amount of eosinophilic cytoplasm is present, sir.
Right, that's right. So is that all, or you want to add anything else in the description? You made a pretty good description. So most of the points I wanted to cover, you did. A little bit more on the cellular morphology I'd like to ask. If you don't have anything else to add, I will ask the other students.
The pleomorphic cells, vesicular nuclei is present. Other than that, the nucleoli, the eosinophilic nucleoli, macronucleoli is present, sir. I don't know what else to add.
Okay, fine. So anybody else wants to add? Ryan, Tanuja, all the other third year PGs here?
So I go with description. So one purpose is surface answer. Again, this might be the feature of
Okay, so you're also thinking of minimum. So can you see my eye on the screen? Yes?
Yes, sir.
Okay, so that is ulceration. Correct, okay. Jayant, your voice is actually breaking up. So to hear you. That's right, that's right. So look at the organization, location of the nucleus in most of the cells you can see in this field, right? So melanoma is a good differential. I agree. Wherever you see a tumor like this, which has prominent nucleoli, right, very high-grade looking, magnetically active. Mucosal melanoma is good, so melanoma is always a differential to have in this case. But otherwise, look at the repetitive kind of psychological pattern you're getting, right? So the nucleus is located eccentrically here, okay, and we have a cytoplasm here. Many of them have a cytoplasmic off as well, right? So same again in this cell, this is a little larger compared to the other cells. Again, a single prominent nucleolus eccentrically located. So this is a kind of a plasmacytoid appearance we are getting in almost all the cells which are present in this field, right? Similarly here also. Right, most of the places the nucleus is located eccentrically. So otherwise all the other features were good. You've said diffuse, you've said you identify the mucosa, you identify the ulceration, mitotically active, nuclear features, right? So to go ahead with the summary of the findings, it's a short duration of progressive clinical symptoms, right? In a 40-year-old middle-aged man with an infinity mass, loosening and histio of fatigue as well. Right, we are seeing diffuse infiltrate of these cohesive cells in the oral mucosa, plasmacytoid cells with single prominent nucleolus and mitotic activity. Right. So what next would you like to do, Abhinaya?
So since I had a definition of a melanoma, I would like to do an S100 and HMB45 to see a melanocytic lineage is present. If plasmacytoid cells are coming into picture more like a plasma cell dyscrasia kind of thing, I would like to do a CD138 also to differentiate whether it is plasma cell or epithelial cell in that sense, melanocytic cells or in that sense.
Right. Okay. So we'll go ahead with the approach to the case now. Right. So just a general poll question to all the audience here. What kind of a lesion would you categorize this into? Would you consider this as an inflammatory or infective? Is it a normal histology for the site? Do you think it's a benign tumor or do you think it's a malignant tumor? Looking at what you have seen so far.
Malignant tumor.
Right, so pretty straightforward features. We have seen the history, we have seen the nuclear features, we have seen the mitotic activity. Correct. Somebody is suggesting possibility of lymphomas also. So generally we all agree on this, right? It's a neoplastic malignant lesion. Right. And what line of differentiation do you favor here on morphology? That's the next question. Right? Depending on that, you will go ahead with possible differentials and figure out a IHC panel to work around the case, right? To get to a final diagnosis. So what differentiation do you favor here? Can be more than one also. So B and D, okay. Right. So lots of E is also germ cell also. Okay. Right. So mostly I also agree with lymphocytic and melanocytic. Okay. So again, to approach this kind of a case, and many times you have got a proper DD here, right? But often it happens that we have not encountered a set of histological findings before in our training. Okay, and especially when it's a high-grade tumor and we don't know what specific entities they are, it always helps to follow a certain pattern of how to approach the lesion, right? To be able to give a best possible kind of an answer to categorize what the lesion is. And to go into stepwise so as to either pick up, is there any mix-up in the tissue which we are seeing? Is there any mislabeling of the sample? It's always first good to look at, is the tissue we are seeing, is it appropriate for the site which has been biopsied? Okay, so here we saw squamous epithelium. So just looking at the squamous epithelium, can you say, is it from the oral mucosa or is it from anywhere else? Are there any features which help us do that, Abhinaya?
The keratin that is present, it's not in, it can differentiate whether it is of a mucosal or it is a surface. The keratin that is present and the thickness of the epidermis again can help in differentiation.
Sure, keratin is one, but some of the lesions in the oral cavity can also have keratinization. There's another layer which is usually not very prominent in the oral mucosa. It's more or less absent. That's the granular layer. Okay, and obviously, and the other aspects, like if it's a skin biopsy, you want to differentiate it from, you can always look at the dermal appendages, right?
Yes,
so always when you're looking at a tissue with a squamous epithelium and it has come to you as oral squamous biopsy, always make sure that the mucosa is squamous, right? It's a mucosa squamous. That's one way you can be sure that you're looking at the right biopsy of the same patient. Second is from the site also, you need to also get an idea of what are the different natures of biopsies which are done, right? In the oral mucosa, this, for example, I told you it was an incisional biopsy, right? The size of the tissue itself on the low power was also matching that description, right? It was quite deep and we could see a lot of a big chunk of tissue in the epithelium. Okay?
Yes,
and that is also important in context of skin biopsies, right? Usually the skin biopsies are small biopsies, but sometimes you do get shave biopsies of the skin, right? Sometimes they take very deep biopsies so as to include the deep subcutis whenever they're suspecting paniclitis and other diseases. So these things should always be at the back of your mind whenever you look at it. Am I looking at the right patient's site or not? Okay. That is one thing. Of course, we are all agreeing that it's not a normal tissue. We are all agreeing that it's neoplastic. If it's inflammatory, again, you go ahead and look at infection or non-infection. But here again, we agree it's benign, it's malignant. Lineage-wise, we all agree. It's either lymphocytic or melanocytic, right? I thought it was more lymphocytic. And when we think of any lymphocytic malignancies, we discuss the plasmacytoid nature of the tumor, right? So clearly, it's not a precursor tumor we are thinking of. We're thinking of a mature tumor, which is a non-Hodgkin's lymphoma. Coming to the differentials. So you said plasma cells dyscrasias, right? Can you be a little more specific? What kind of plasma cell tumors do you think can arise in the oral cavity in a setting of a middle-aged person, which can progress so rapidly and cause metastasis and tuberculosis?
A lytic lesion, plasma cell myeloma, that's plasma cell myeloma causing eruption, the bone distortion that is present can lead to epistaxis and lytic lesion that is seen on the X-ray in the CT that can be present.
Sure, but would it just be a regular multiple myeloma, or would you think of any other specific change in the context of a myeloma also? Given that you have seen cells which almost all consistently have a prominent nucleus.
It is premature plasmacytoma can be considered a premature neoplasm, like a plasmacytoma can be considered.
Okay, so anyone else has any other differentials here? Jayant, Ramjit, and
the third differential as the second differential as DLBK.
DLBCL is also fine. Okay, so which morphologically which type of DLBCL would this be? What would you categorize these cells as? Cells with a permanent nucleolus?
So you're asking the type of DLBCL?
Yeah, so DLBCLs depending on the
DCP and non-DCP, you're asking that, sir?
so we can have immunoblastic DLBCLs. So usually cells with, yeah, and one of the participants here has already raised the other possibility of there's a lymphoma called as a plasmablastic lymphoma, right? So morphologically these kind of cells which are plasmacytoid which have uniformly a prominent nucleolus, right? And plasmablastic lymphoma, if you look at the clinical presentation, this is also how it typically presents. It presents in the oral mucosal site, okay, rapidly progressing, high proliferative activity. So here the set of differentials considering the morphology were, right, plasmablastic lymphoma, of course, DLBCL is one of the DDs. And in the context of myeloma or any other lymphoma, for example, if this person, for example, had multiple lymph nodes in the neck, okay, one of the lymph nodes was showing this kind of a pattern, okay, in the background of a follicular lymphoma, for example. In those contexts, we would consider a plasmablastic transformation in a otherwise any other kind of lymphoma. Even in multiple myeloma, there can be a transformation of the plasmablastic type, right? So that's a aggressive transformation. So considering that most of these cells are plasmablasts, these are the differentials. So with these DDs in mind, what is the IHC panel you recommend? You can also include melanoma. We already discussed that. As standard HMB45, melan is fine. For the lymphoma person, what would you go ahead with?
So for DLBCL, I would go for the B markers first, sir. CD19 and CD20, followed by CD10, and followed by BCL6 and non-common.
Okay.
So plasmablastima, as I already discussed, CD138.
CD1.
Melanoma, obviously, HMB45, soft and melanoma.
Okay, I've got answers from Grishma, Mumban, Kappa, and Lambda also. So let us look at what the IHC panel came up, right? So it is CD3 negative, CD20 negative. Anything else? What would you do now?
So now, so what about the melanocytic markers?
Melanocytic markers are also negative. Anyone else can chip in anytime. So, okay, I've been asked for 138 kappa. Okay, 138 kappa lambda will come to 45 and Paxil are also negative, right? So this is one kind of a lymphoma where, like, if you are not really aware of the diagnosis upfront, okay, or if you don't know what its typical immunophenotype is, it takes a lot of time to get to the final diagnosis essentially. So if you have seen this kind of a case coming in your routine reporting and being worked up, it is a very difficult case to forget about, right? Because generally, what are the typical markers we get to see in lymphoma? DLBCL, mostly we get CD20 or Pax5. The initial set of markers usually tend to come positive, right? When we talk of the usual non-Hodgkin's lymphomas, okay. But here this is a lymphoma which is a terminally differentiated B cell type. So generally the morphology, immunophenotype also overlaps a lot with that of plasma cells, right? So we get CD138 positive. We can get CD79 positive, right? And MUM1 is also typically positive. So always whenever we are approaching NHL immunophenotyping, CD20 and 3 is one of the initial markers we start, right? Always have a B and a T together, right? Because both are complementary to each other. Never decide upfront that this is a B NHL and I'm going to do only B markers. Okay. Always have a complementary T marker to interpret alongside. Okay. And if the initial set of marker is negative, there are immunomarkers which detect expanded range of B cell differentiation, right? So always go ahead for that. CD79A is the next in line. Pax5 is the next in line. So in CD138 to cover the plasmacytic side of differentiation, given especially in this context where we were seeing plasmablastic morphology. Okay. And typically in this tumor, Ki67 is also very high. Okay. It's around more than 90% most of the time. And we found lambda restriction in this case. And CD56 is one of the markers which is done in this context where you are considering is it a plasmablastic lymphoma or a myeloma with transformation. Okay. And the other markers, the current WHO gives you the essential diagnostic criteria for this tumor, right? You're also meant to rule out whether it is a positive DLBCL or is it a HHV8 associated. That is the primary effusion lymphoma which occurs in a solid tissue, okay, outside of the fluid setting. And EBRH is positive in around 60 to 70% of these cases. And if any one of you had thought of this diagnosis earlier, do you know what is another important association of this tumor, clinical association of this tumor? Yeah, I'm getting answers in the typing in the chat box here. So Grishma says it is usually associated with immunocompromised status. Okay, so often around 40 to 50% of these patients are immunocompromised, either in the form of retroviral positive infection or transplantation or any other chemotherapy induced in this, right? And for clinical correlation, of course, these are the things you need to rule out, right? Abhinaya was considering it was a multiple myeloma with the plasmablastic transformation. So some IHC markers, textbooks will say help us differentiate both. But to be sure, we always need to go back to the clinical history and identify, right? Is the patient having a multiple myeloma kind of presentation? Okay, does he have multiple ITP? Does he fulfill the other criteria of having an M and M component? In this case, it was only focal lesion limited to the oral mucosa, okay, presenting that way. And therefore, this was a case of a plasmablastic lymphoma. Okay. For exam, it is not necessary. This is a rare tumor in any case. Okay, so it's not necessary that you would have seen such a case in your training. The thing to do in such a case is classify as much as you can, right? Go as far as in your classification as possible. Try to identify the lineage, right? We got to the state where we were able to say it's a melanocytic or a lymphocytic tumor, right? Under the lymphocytic type, try to go ahead for the is it a Hodgkin's, is it a precursor, is it a non-Hodgkin's? Okay. Non-Hodgkin's, if you have seen such a case, you will recognize this, that this is a scenario where plasmablastic lymphoma needs to be ruled out, right? Otherwise, give the IHC panel and you can discuss that. It is acceptable. You may not get the final diagnosis in your differentials each and every time. Right? The approach here is more important. Right? Try to identify the tissue, try to use the proper descriptors, be specific. And always important thing is, in such a case, don't get worried and try to ask for help. Right? Usually there is always either a senior resident or any other junior faculty who is present while you are seeing the slides in your exam, right? So never try to ask for a diagnosis or ask for help, because it is very easy to make out the difference between your description and what differentials you are giving. Okay, so if you're not able to arrive at a diagnosis on your own, still by asking your colleagues or asking the senior if you are offering a differential diagnosis, the stark contrast stands out. Okay, and such cases get discussed a lot. Right? So try to avoid that. Try to be honest. Try to go as far as you can classify and recommend further work as per your differentials only. Okay, don't give irrelevant markers for the differentials which are not ever considered or described or put on paper. And in the context of lymphoma, it is important to know these unique clinical pathological entities or typical clinical presentations. Like plasmablastic lymphoma, this is a typical clinical presentation. Presents in the oral mucosal sites in immunocompromised patients with this kind of morphology. Similarly, there is the acute lymphoblastic lymphoma, okay? Young male mediastinal mass. So in such a case, if you see lymphoma, always include this as a differential and give markers, give the premature markers, TDT, CD34. Those things, don't miss it up. Don't just work it up as a usual non-Hodgkin's lymphoma, 320, then don't just keep DLBCL there or any other lymphomas differential. Same thing with Burkitt and primary mediastinal large B cell. Other thing is, whenever you are writing mitotic activity, right? Nowadays, this is a consistent change across all the WHOs, right? You are supposed to report mitotic activity per millimeter square, not per high power field now. Okay. So do you know how do you convert a high power field to a millimeter square area? How do you calculate it for any microscope you're looking into? Anyone? Anuja?
2 mm square.
Okay. No, I'll give you an example, right? Say your microscope, for example, you're looking at a 40x field, right? Okay, your eyepiece you are seeing, it has a field number of 20. Okay, so 40x objective, field number 20 of your eyepiece. So how do you calculate how many fields of your 40x make a millimeter square? Correct. I've seen an answer in the chat box. That is correct. But this is what you should know. And how do you otherwise calculate? Like if in a routine case when you're presenting to your consultants, how do you assess the mitotic activity per millimeter square? Because that is important. That is a consistent change you need to bring in your the way you write, right? Your way you describe your slide. Because this is common across all tumors. Because 40x, I hope you know that the size, the area of the field differs from microscope to microscope, right? Depending on the field number of your objective and the objective magnification you're using. Okay. So per high power field, the count will not be same with configuration of two different microscopes. So this is one basic thing you all need to learn. Make it a habit to report mitotic activity in millimeter squares. So in this case, like I said, so the two parameters you need to know is one is the magnification of the objective. Here it was 40x, right? Other thing is the field number of your eyepiece. Here I gave you a field number of 20. Okay, so you just divide 20 by 40. The field number of the eyepiece divided by the magnification of the objective is 40. That gives you 0.5, right? So that is 0.5 mm is the diameter of the circle you see in a 40x field for that particular microscope. Okay. Usually the consultant microscopes have a higher field number. That is why you tend to see a larger area of the slide. Okay. And the student microscopes field numbers range from 18 sometimes. Okay. 18 is the minimum I've seen. 18 to 20. Okay. So the size will vary. So if it is 18, you need to divide 18 by 40. Okay. If it's 22, you need to divide 22 by 40. Whatever, if you do the division, you will get that 0.5 millimeter in this case. That is the diameter of the circle. So once you have the diameter of the circle, it's easy to calculate. Right? You do pi r square. That will give you the area of one field in 40x. With that, you can calculate how many fields of your 40x make a millimeter square. Okay. So once you calculate this for your microscope, it is constant for all the cases, right? Usually with a field number of 22 for consultant microscope, it comes to 5 fields. 5 fields of my microscope in a 40x will make a millimeter square. Okay, so it's a huge difference. What we used to report in 10 high power fields earlier is reported in 5 high power fields now. Okay, so it's a major difference. So just remember that and keep that in mind to mention your mitotic counts in millimeter square in your exams. Okay, so going on to the next case, we had so who wants to present this? Can we have Preeti?
Yes, sir.
Yeah, anyone else? It's fine. So who's taking this? Ramji, okay, go ahead, Ramji.
So for week male confined with persistent jaundice and liver biopsy taken.
Okay. So at this stage, you want to know anything else?
No, sir, 4 week confined persistent jaundice, liver biopsy taken.
Correct.
Yes, sir. Let's just persistent jaundice, after jaundice to severe jaundice maybe.
Okay, so clinically, do you want to know what kind of jaundice it was?
Sir, after 50 maybe it will lead to. I want to know, sir.
So what are the usual broad classification of what are the usual two different types of jaundice which are very different pathogenetically?
Sir, obstructive jaundice and destructive jaundice.
Obstructive, okay. You mean okay, fine. Unconjugated hyperbilirubinemia and conjugated. And
Yes, sir.
somebody has said physiological, but why is this not physiological jaundice?
It should not be.
Physiological jaundice, reduced jaundice after 4 or 5 weeks.
4 or 5 weeks is too long.
No, sir, 2 or 3 weeks. After 3 weeks, sir.
Okay. Generally, the rule is around 2 weeks, right? If the jaundice is persisting in an infant for over 2 weeks, it gets investigated. Right? Especially if it is the conjugated type, it is almost always pathological. Okay. Unconjugated hyperbilirubinemia can exist. Okay, because as soon as the liver enzymes are not fully functional. Right? So, for partly earlier for the 2 weeks, having unconjugated hyperbilirubinemia is expected, right? But it should go down by 2 weeks. Okay. If it persists, then it is investigated. In this case, I'm telling you it's a conjugated hyperbilirubinemia, right? So, and therefore a liver biopsy has been done. So, can you describe the findings here, Ramji? Yeah, you can see the image now, I think.
From liver biopsy.
Right.
So the hepatocyte cells and hepatic vein are dilated and portal tired, and near the portal tile are dense inflammatory infiltrate and fibrous.
Okay, Ramji, I'm going to stop you there. You said hepatic vein. Do you mean these?
Yes, sir. Yes, large central vein here. Central vein.
Okay, so can you see the arrow where I'm pointing to?
No, sir.
No, sir.
Okay. So the large spaces here, the large white spaces.
Large white space is central vein.
You're calling that as a central vein. Okay, do rest of you agree here? Abhinaya, Anuja, Harshita. Is that a central vein or is it something else?
It's not the central vein.
Okay.
It's part of the portal triad. There is bile proliferation along with the venule that is present, and that is an arterial. There is an arterial, I guess, not a central vein. It's not a central.
Correct. So central vein is what you would find in between the lobule, right? In the center of the hepatic lobule. So that area, Ramji, which you're describing is in fact the portal tract. Okay. And what are the components of the portal tract? What three structures do you see in a portal tract?
Ciliary, hepatic artery.
Correct.
Portal vein.
Correct. So that's the portal vein, right? You said hepatic vein once, you said central vein. So that is the portal vein. Okay. Right. So bile duct, hepatic artery, and the portal vein. Okay. So go ahead. We are seeing portal vein, and Abhinay has said there is bile ductular proliferation. You have said there are inflammatory cells. Let's go to the next.
Hepatocytes are around central located nuclei.
Okay.
Prominent nuclei. Then cytoplasm are there.
Okay. So what do you think about the thickness of the canalicles here? Thickness of the hepatocyte
Increase, sir.
increase. What should be the normal? So what is the normal hepatic trabecular thickness in adult?
0.5 mm. Yes, sir, 0.5 mm.
Correct. So it is not a numerical cutoff. It is the number of cells which are present in that trabeculae, right? So in an adult, you see 1 cell thick trabeculae, whereas in children, around 2 is also normal. So here we are seeing mostly 2 cell thick hepatic cords, right? That is all there, which is expected for this age. So that is nothing abnormal there. Okay. Right. So what can you see here?
So giant cell transformation.
Giant cells are also seen noted there.
Correct. So here we are seeing giant cells,
And here also inflammatory cells.
inflammatory cells. Okay, we'll come to that. And what is the finding I'm showing here?
The
Yes,
beginning.
sir.
Cholestasis.
So
Bilirubinosis, sir.
Correct. So what kind of cholestasis are you seeing here?
Intracytoplasm.
Intracytoplasm.
Okay, so in the picture on the left side, right, left top, what is the cholestasis? What kind of cholestasis would we call that? Right, picture on the right side where you're seeing bile ducts, what kind of cholestasis would that be?
Cytoplasmic.
Correct. Somebody said ductular, right? So picture on the right, can you identify the bile ducts on the right side image? Right. So,
Because that it is inside the bile duct, inspissated bile duct, which is
correct. So correct. So that green circular deposit which is present in this bile ducts, right? Bile ducts you identify by those cuboidal cells, right? With the large nucleus and little bit of moderate amount of cytoplasm, right? And they're all forming a duct-like structure. Here the lumen is very almost not quite prominent because it's a ductular reaction. Okay, bile duct comparatively will have a more prominent lumen in the center. But in any case, we can see that the bile plug is present within the bile duct tube, right? So that is called as a ductular cholestasis. Okay, and in the top left image, that is a canalicular cholestasis. Right, so we know that hepatocytes in between they have a canalicus. That is where normally the bile flows out from the hepatocyte into. Right, a lot of these canaliculi join together and form the bile duct, which drain outside. Okay, so that is canalicular cholestasis. And in the picture in the center, that is also canalicular cholestasis. Okay, we can see there are two plates of hepatocytes, and in between there is a circular place where the cholestasis has occurred. So that's also clear. Right, and here what is the finding you're seeing? My query is mainly regarding the cells which you are finding in the in between the hepatocyte cords. What is that feature?
Ballooning degeneration.
Okay.
lymphocytes.
Okay, so when we talk of these changes in the hepatocyte, one is ballooning and other is feathery, right? Which one of the changes is usually seen in cholestatic diseases? So cholestatic diseases usually causes a feathery change, right? Feathery change in the hepatocytes you can identify by presence of these filament-like changes in the cytoplasm, right? Ballooning you will see a lot of fine granules and the cell size will increase, whereas in the feathery degeneration you will see a lot of filamentous structures also in the cytoplasm, right? I'm getting a few answers from the chat. So what do you think these dark small cells are which are present in these in between the hepatocyte cords, the sinusoids?
Hematopoietic cells. These are extramedullary nucleus is present.
Correct. So whenever you see this kind of a round nucleus with such dense dark staining of the nucleus, those are usually erythroid cells, right? And those are one of the common type of cells you'll see in EMH. And remember, this is a 4-week-old child. So generally, in conditions where there is a stress, there will usually be extramedullary hematopoiesis in the liver. Right? Liver is the main site where hematopoiesis occurs in the intrauterine life, right? And same finding is there in the other picture also. We can see on the site also, right, towards the bottom at 6 o'clock. Right? So you can see large cells. So you will not be alarmed by that. You should be able to recognize those are megakaryocytes. Okay, so I need a cursor. So now can you see the pointer?
Yes, sir.
You see my cursor? Yeah. So this was the megakaryocyte I was pointing to. Okay? And these are the cells which are extramedullary hematopoiesis. Okay. So this is the hepatocytic cord. That's a cord. In between is the sinusoid, and in the sinusoid we can see these cells with dark nuclei. Right. So that is a extramedullary hematopoiesis. That's how you see that. And these are all the in between hepatocytic cords. That's again the canalicus between two hepatocytes, and we can see this bile plug in there. This is a bile ductule within which we are seeing a inspissated bile. So this is all ductular cholestasis. Okay. So now, of the findings, right? We have infant with persistent conjugated hyperbilirubinemia. Okay, we are seeing portal tract expansion. We are seeing portal fibrosis. Okay, biductal proliferation and ductular and canalicular cholestasis. Okay, we are also seeing genital transformation with extramedullary hematopoiesis. Now, among the features which I have written in points 2 and point 3, which one do you think is more prominent? Do you think that genital transformation was more prominent or the portal tract changes were more prominent?
Portal tract changes were more prominent.
So everybody agrees with that? Do you think the portal fibrosis and ductular reaction cholestasis was the dominant pattern in this case? Right, I think so. So here. Right. In the previous case, essentially we were discussing what is the diagnosis there, depending on the findings we saw. Right. Here, essentially try to distinguish what we are trying to identify what is the pattern of reaction occurring here. Right. We are not talking about a single disease. We are trying to identify the pattern of reaction. Okay. And essentially, in this context of infant with conjugated hyperbilirubinemia at 4 weeks, it is important to identify an obstructive pattern and differentiate it from a hepatitic pattern of injury. Okay. So hepatitic pattern generally will have a lot of inflammatory damage, evidence of inflammatory damage in the lobules. Okay. That will be more prominent. And in such cases, the genital transformation is more diffuse. There is more extramedullary hematopoiesis. Right. You can see hepatocyte necrosis, hepatocyte dropout, consummate bodies. Right. Those are the features of hepatitis. Okay. Whereas here we can see the portal tract features are more predominant. Fibrosis, expansion, ductular reaction. And so basically, why we are talking about only identifying the pattern here is because some organs, it is very difficult to, especially in the non-neoplastic diseases, when we talk of liver diseases or inflammatory skin conditions or medical renal diseases, it is difficult to get at a single specific disease entity just based on the histopathological findings, right? Diagnosing a disease in these organs requires clinical information, biochemical information, radiological information, okay? And these organs generally have a injury pattern which is common across a lot of disease entities. Okay, for example, in this case, obstetric type of pattern can be seen in varied diseases like biliary atresia, it can be sepsis, cystic fibrosis, infections, alpha-1 antitrypsin deficiency is an important differential in this context. Okay, even possibly bile ducts. Whereas the hepatitis pattern of injury can be seen in hypopituitarism, again infections, some metabolic conditions. Okay, and even usually it is idiopathic where we are not able to identify what is the specific cause. So the point here is when we are writing the description and writing the bottom line of these cases, it is important not to go ahead directly and give a specific diagnosis, right? Focus on the pattern, and focusing on the pattern, if you know what are the differential diagnoses which are associated with the pattern, ask for the clinical history or advise biochemical tests or other markers which will help you lead to a specific diagnosis. And in this case, in biliary atresia and neonatal hepatitis, further issue is that a lot of these features there is an overlap. Okay, so in one end of the spectrum you can see very well developed biliary atresia findings, and in the other end of the spectrum you can see clearly hepatitic kind of a pattern. But there will be many cases where there will be overlapping features. Okay, so all the features which we have seen so far, genital change, liver inflammation, hepatocyte loss, pattern of fibrosis, ductular reaction, and EMH, they can be variably present in both of these. Okay, it is the dominance of one over the other which helps us decide what is the predominant pattern of injury there. Okay, and many times to aid in that, to decide which is the dominant pattern, to make it more objective and less subjective, there are many scoring systems which have been developed, right? So none of them have a consensus and a universal acceptance such that it is used routinely. But scoring systems also essentially incorporate these patterns. They give various scores to that 0 to 4. So you grade genital change from 0 to 4, you grade the ductular reaction from 0 to 4, and depending on what the score is coming, you either favor obstetric kind of pattern or a hepatitic kind of pattern. Right? Similar kind of diseases you can similar kind of issue you can encounter in neoplastic pathology also, right? That just based on the morphology, it is difficult to categorize a tumor whether it is benign or malignant, whether it will behave that way. Some examples are like adenocortical adenoma and adenocortical carcinoma, right? Obvious cases on the either end of the spectrum, it is fine. But many cases, it is difficult to predict the behavior. So similarly, there are scoring systems for these tumors. So be aware of these entities where such scoring systems are there. Okay, so whenever you are describing these kind of cases in your exam, try to mention the different elements of the scoring systems. Okay, and be aware that you cannot give a single specific diagnosis straight away in these cases. Okay, based on the scoring systems, it is a probability which you are giving. Right. So, question 3: which one of the following would you write as the diagnosis for this case here, which we just discussed? Right? Would you call it as a extrahepatic biliary atresia? Would you call it B, C, or D?
B. Obstructive pattern of cholestasis compatible with extrahepatic biliary atresia.
Correct. Right. So, right, a lot of the audience is also answering the same. Here, the focus is on the obstructive pattern, right? And since we saw, right, many other diseases can also cause an obstructive pattern, it is important to just say the pattern and correlate with other clinical findings to confirm that it is extrahepatic biliary atresia. Usually, clinicians do radiological tracer studies, right? They can inject the child with a tracer which gets excreted in bile, right? So, depending on how much of that tracer is getting excreted into the duodenum, you can detect whether there is any biliary atresia or not. Intrahepatic cholangiogram is another way where they inject the dye and look for the patents of the bile ducts essentially. Ultrasound is a routine test in these cases, and usually you will see any abnormality in the gallbladder. Many times the gallbladder is atretic or absent. Right? All these features are important for us to ultimately diagnose the child as having a biliary atresia. Right? It's not just the obstructive pattern of liver disease which is important here. So, for example, it is important, especially in liver, skin, and medical renal disease, to identify the reaction pattern. Okay, focus on the pattern. Then know the differentials and advise the further workup accordingly. And in most of these cases, it is important to describe in a systematic manner. Like, so for example, liver, you look at the adequacy of the liver biopsy, look at whether you have got enough number of portal tracts or not. Go ahead with describing the portal tract, then describe the hepatocyte tubules, then look at the vasculature. Similarly, for kidney, we have the same thing, right? We look at the glomeruli, we count the number of glomeruli, look at the tubules, vessels, right? So all those components are important. So that kind of an organization is important to be seen when you write description for these cases. Okay, if there is any related scoring system, mention that, right? And of course, etiologicals and DDs are there. And somebody in the chat asked, is gap validity proven for pseudocytoma? It is not. So even WHO also says that it neither supports nor denies usage of these kind of scoring systems, right? Ultimately, in this metastasis is what proves malignancy in these cases, right? But they have left it to the individual person. And in any case, the elements of the scoring systems are important. Right? You still anyway have to look for the vascular invasion and angio invasion. For you as exam going PGs, it's important to be aware of the elements of any scoring system so that you look for those specific findings and mention them. Okay, in any given case. Okay. So any questions in that the two cases we have discussed so far? Or can we go ahead? Right, we'll go ahead with the case 7. So, who wants to present this? Jayant, can you?
Yes, I will.
So, 77-year-old female with mass in the right.
Past 6 months. Yeah. Section exam shows tumor cells, round tumor cells arranged in sheets, nodules, tabacular, and few arranged singly. These tumor cells show small blue morphosis surrounded by vessel and invasion fluid, probably. The individual cells show INC signature. The INC ratio, round to oval nucleus, moderate amount of cytoplasm with inconspicuous nuclei.
Okay.
I would do the disease of small round blue cell tumors.
Small round blue cell tumor. Okay, but you said moderate cytoplasm there, right?
Sure.
Right, so generally, small round cell tumors we think of in what context? Right, in those usually the cytoplasm is very little, right? There are very few exceptions, like maybe atypical leavings which may have a little bit of more cytoplasm, but otherwise most of the small round blue cell tumors are small and blue, right? That's why they appear blue. So here, what is the tumor appearing like? If you look at the spot, is it more blue or is it more something else?
It's more clear, maculated.
Right. If you look at the spot, is it more blue or is it something else?
The first it was blue.
Yeah, okay. If at a lower power, I agree. Fine. It is. Yeah, you can't really make out how much cytoplasm is there. Okay. So yeah, cytoplasm clearing is quite apparent here, right? Even at this power, I can look at this cord of cell having moderate amount of this clear kind of cytoplasm. Okay. And here it is forming a cystic kind of a space with a lining and containing some fluid. Any other pattern you've seen? This is again a cord setting up. Right. So any other pattern which stands out in this?
Solid.
Okay. Solid sheet. What else? Anyone else? So this is the pattern I'd like to highlight and for you to know. Of course, it's difficult diagnosis. I don't expect you to reach. But yeah, the finding you realize why it is important once you know what it is. So anything else? Is any other kind of a repetitive pattern is standing out here? Somebody says alveolar. Alveolar not really. You mean alveolar in the sense of alveolar RMS, or do you mean it in the sense of alveolar soft part cell? So usually those are bonded clusters in ASPS surrounded by at least capillaries or basement membrane. In case of alveolar RMS, the cells in the center would be viscoadhesive and falling out. Right? None of that seems to be happening here. Can you see that pink eosinophilic stuff in the center?
Island blocking.
Correct. That is one possibility. It is a pink material depositing in the center of clusters of several of the cells. Right? And it's a repetitive pattern. Do you agree?
Yes, sir.
Right? This is the low magnification of the same. That's the high magnification of the same. Right? It is present in different areas of the tumor. Somebody's called it a rosette. Possible. Okay. It is densely pink. It is like even at this power, it doesn't appear to be fibrillary. Okay. And in the nose, of course, if you're thinking of a round cell tumor with rosette, we have a certain set of differentials to keep in mind there. Okay. But here again, it's a lot of clear cytoplasm, blank nucleus, right? Very not high grade tumor. So what should be your approach here now? So what kind of DDs do you think here? Okay. So I've already given you the breakdown here. Okay. So the issue to consider here is in this kind of settings, always think of both primary and metastatic tumors. Okay. Can this kind of a tumor be primary to the site? Mets is a very important possibility, especially whenever you look at this clear cell tumor. Okay. So what primary is very important to think of here when you see a clear cell tumor presenting at odd sites like this in the nose, for example?
A salivary gland like tumor, clear cell tumor.
Renal clear cell.
Correct. Renal clear cell is important. It's the most common one, right? That is the great mimicker. So RCC is known to present with odd metastatic sites here, and when you work up, you discover the primary. So that is very well described in my textbook. So clear cell RCC should not be one of the differential. So that we are discussing of metastatic tumors. What primary tumor can be there here? We know we saw the basement like material, right? Usually material clear cells. So some odontogenic tumors can be like that. Clear cell odontogenic carcinoma is one of that. Salivary gland tumors can be primary at the site here, right? Salivary gland can I couldn't hear you. Tanay, the issue with you is still persisting. Right, so parathyroid is another DD and thyroid. Okay, so what would you do next now? Would you make an extensive IC panel and start working up? You're saying sinonasal venous cell carcinoma. Okay. Would you like to get special stain done for miscellaneous glycogen, or would you ask for more clinical and radiological info?
B.
So practically, if you get such a case in your reporting, what would you do? And if you
Ask more clinical and radiological.
After clinical and radiological info for searching the primary, then you would like to do IC.
Right. So I agree. That is an important step to do, right? So rather than try to work everything up sitting at a microscope, right? It is important to call our colleagues and ask what is the kind of scenario. Many times you get very useful information, right? Otherwise, sometimes it rarely happens that the patient hasn't been yet worked up and you'll have to wait a while to get all the information. But most often you'll get very good information. And in this case, what information we got was that this patient already also had a solitary thyroid nodule in the right lobe, right? So now do you think you need to do an excessive IC workup, or is there any way you would go ahead in this case? Right, so the next thing here, what we did was FNAC of the solitary thyroid nodule, which came out as a follicular neoplasm, right? Category 4 FNAC was reported, and on dissection this showed a thyroid carcinoma. Okay, and to confirm that this was indeed a mets, we saw that there were those cells in between which there was that eosinophilic material which was being deposited in a repetitive pattern, right? So those were follicles retrospectively, right? And TTF and TG thyroglobulin also came positive in this case. So this was a case of follicular carcinoma metastasis, and clear cell change in follicular carcinoma is described. It is not very often, but among the thyroid carcinomas, clear cell change is more often seen in follicular carcinoma. Okay, so primarily for exam, here it is difficult to get to a specific diagnosis that it is a thyroid mets, right? It is not something you will think of straight away, but it is important to recognize that it could be either a primary and metastatic, give differentials on both sides, recognize that it's a clear cell tumor, what it is falling into, and give differentials, and also learn to how judiciously employ and interpret IC. Always feel free to ask for clinical information and additional information. Right? Exam is not just meant to directly jump into your ICDs and advise mutations. You can always begin after describing your slide findings. You can ask the examiner what are the clinical findings in this case. Is there any mass? I'd like to know. Okay, so many examiners are forthcoming to do that. You need to show how you are going to approach the diagnosis to this case. Right. Next case, 55-year-old male with a painful nodule on the dorsum of right hand for past 4 months. Can we have Harshita? Harshita, you there?
So-
Yeah, Harshita. So this case is you can present.
55-year-old male with painful nodule on dorsum of the right hand for the past 4 months.
So what do you see here?
There's a papillary sort of, not papillary, there's a well-defined area in the center, which is different from the remaining area. And this seems like a proliferation of the granulosa cell layer.
You're talking about skin biopsy. You mean the granular layer is proliferating? Center area, which one are you talking about?
So the one with finger-like projections.
This one?
Yes, sir.
Okay. So what do you think that is? This is skin biopsy, right? Remember.
Yes, sir. Looks like proliferation of the granulosa or the spinosum.
Why particularly that layer? Okay, just so there's proliferation of the squamous epithelium. Let's just stick to that, right? It is irregular acanthotic. It doesn't look like a normal flattened layer of epithelium which sits on the top, right?
Yep.
Keratin pearl, somebody saying fine, agreed. Anything else? Where else do you see a lot of activity happening in this?
On the lower right side, there's a hyperchromatic nuclei, and there's
Okay,
a
so this
focus
is
of
local, right? So don't just you cannot see the nuclei at this cover, right? So just say this area there is higher cellularity, right, compared to the rest of the areas. So this whole part of the skin is dermis, right? That is epidermis. This is dermis, and that is the lower half. That is the other half of the skin biopsy. So yeah, what we are seeing, what are these structures you're seeing, Ashita?
the adnexal structure, the
Correct.
The
So, that's the adnexal structures, yes. So essentially, we have a lot of activity or increased cellularity in patches, right, which we are seeing in the dermis. Okay. We'll go to the next slide. So that's at a higher part. So can you recognize what is forming that increased activity? What is the composition of cells in that increased activity? Okay, somebody saying DFSP. Remember the clinical presentation. Okay. So now can you see what kind of cells are forming these increased zones of cellularity? That's the epidermis here, and these were the areas which are appearing very hypercellular to you, right? What kind of cells do you think these are, and what cells are these?
Neutrophils.
inflammatory cells, mainly composed of lymphocytes and could be neutrophils.
Okay, so these are neutrophils, right? So this is inside shows the higher power of this area, right? So we are seeing a lot of neutrophils. Many of them are fragmented. And what are these cells?
You can also see a transmigration of polymorph in the squamous epithelium.
Correct. We can see some inflammatory cells entering the squamous epithelium. Okay, so those are mostly lymphocytes. So lymphocyte exocytosis is there. Anything else? What do you think the structure is? So if I say there are a lot of, somebody said epithelioid, somebody saying hemophagocytosis. Okay. What if I say there are a lot of histiocytes in the periphery around like this, and there are a lot of neutrophils in the center? What will that make this?
Abscess formation.
Correct. So a lot of neutrophils segregated in a localized space like this makes it an abscess. A lot of these epithelioid histiocytes surrounding that make the granuloma. So when you combine both, what kind of granuloma would that be?
Necrotizing.
Okay.
A separative granuloma.
Right. So which is more appropriate? Is it a separative granuloma or is it a necrotizing granuloma?
Separative granuloma.
Right. So that is a separative granuloma, right? And what's the importance of being able to differentiate both?
The differential diagnosis to differ. The infection nature of the infection is going to differ based on this necrotic or a neutrophilic type of abscess that is being formed.
Correct. So the entities, basically the type of infection should consider to be different, right? If you identify this as a separative granuloma, most often what causes this? What kind of infection causes this?
Usually, bacterial or fungal infection do cause the separative kind of granuloma. More in favor of a fungal infection.
Correct. So more in favor. So separative, usually you have to look for fungus, okay, fungal profiles. Whereas your typical necrotizing K18 type of granuloma, first differential would be tuberculosis, right? And in this images, what do you see?
Follicle that is not a follicle. Normal hash shaft is there. Sir. The follicle is present. There is no inflammatory cells around them.
Okay.
One on the lower right is showing a copper penny. That's what I figured. A capsulated organism. I thought of a copper penny body.
That's right.
Body. So
That's it. So my main intention of giving you this slide was I wanted you guys to identify specifically the type of different granulomas you can see. You need to be able to differentiate the granulomas of leprosy from tuberculosis, from the secretive granulomas, right? And there are necrobiotic granulomas. Okay, and sarcoidosis there's a lot of overlap, but still the sarcoid features are a little distinctive compared to your other tuberculosis granulomas. So you need to know what kind of terminology you need to employ when you are describing granulomatous inflammation, especially in a skin biopsy context, right? Second thing I wanted to emphasize was each slide will have several sections of your tissue, right? Each slide, especially on a skin, will have say 4 slices of skin on a single slide. So especially in an exam, even in your routine practice, make it a point to have a look at all the slices, especially in conditions where there are giant cells and granulomas, and when you're looking for organisms within these giant cells, look at all the sections, because this was one such case where this two images essentially show the same area. So in one area, there's no copper penny. As such, there are very few copper pennies in this. If you look at other slice or other section of on the same slide, you'll find the copper penny like. So in an exam, especially when there's a time constraint, you need to decide on a low power and make your observations quickly. Okay, so recognize the type of pattern and try to focus quickly on the granulomas and the giant cells, not trying to miss the sections. Don't just spend a lot of time screening on high power per single section. Okay, go to a lower power and look at the other slices too. That is important. So here to summarize, there is a nodule on the dorsum of the hand, there is irregular acanthotic epithelium, and this kind of irregular acanthosis is also very typical of these kind of fungal infections, right? This is a chromoblastomycosis, where you find those copper pennies, which are pigmented hyphae. And typically separative granulomas, if you see, you look for fungal infections, right? If there are no organisms here, you would advise deeper sections and special stains to look for your organisms there. So from exam point of view, that is important. And this is just an additional image which shows you what is the kind of reaction you're seeing here, inflammatory reaction.
Fibrin,
I'll give you another bar. So essentially, we are seeing a space. Again, a lot of debris is there. Neutrophils are there. We are seeing cells which are lined next to each other parallelly around this line. These cells are all histiocytes. We are seeing some giant cells, right? So, what kind of reaction do you call this?
foreign a giant cell reaction, foreign body type of a giant cell reaction.
Okay. Anyone else? Preeti, Tanay, Ramji, Jayant. So recognizing this is also important because this also indicates that you need to look for a particular kind of etiology, right? That is a palisade. Okay, so these are all cells lining a cavity which are arranged like a catchment, right? So this is an example of a palisading granuloma. Okay, so you've seen a suppurative granuloma, you've seen a palisaded granuloma. And what kind of infections do you get this usually?
Palisading,
Yeah, palisading infections you get it in parasitic infections, right? Many times fungal infection also. Cat scratch.
granuloma is in cat scratch.
Right. So, and again, in this case also, whenever you see giant cells and granulomas, the point I want to emphasize is go at a high power and look at a few of them. Okay. So that's it is a giant cell, and can you identify a fungal hyphae here in this image?
No.
No, right? So that is magnified low power. So look at the higher magnification. Can you see a fungal hyphae here?
To the left.
Yes, sir.
Yeah, so that's the fungal hyphae. So essentially, this is the same image. So if you ignore looking at the giant cells and granulomas and the higher magnification, you are very likely to miss out these kind of findings. And the same thing happens in your cytology as well. So this is a cytology smear. Okay. Any idea where the fungal hyphae is? Can you spot the fungus here?
Yes, sir.
So to look at the giant cells, right? So wherever there are giant cells, go at a higher power and look at them. So this is another image of the same cell which we saw at the lower power there. Here the outlines are easily visible now. Okay, and this is for the magnification, and we can clearly see the branching pattern of the fungus. Okay, so for these kind of cases in exams, it is important to identify the reaction pattern first, right? And suspect that this is a case where it is not a tumor, you have an inflammatory condition, rule out infection first. Okay, rule out infection, and how do you rule out infection? You have to look for the organism, right? And you cannot obviously see the entire slide at 40x. So you have to pick and choose. Easy way to pick and choose is look at the necrotic areas, look at the giant cells, right? Because they are indicating that this is where there is something. That's why I'm forming here, right? So it is useful to identify and pick up these structures at low power also, but many times it's difficult. So be quick and look at the giant cells, and then you can identify these organisms quite well. Okay, so for this granuloma morphology and especially this is important. So each kind of in a very well formed disease, most of these granulomas will have unique features, right? Tuberculosis granulomas, necrotic, coalescent, irregularly placed, a lot of them in the interstitium. Leprosy usually tend to go around the head neck and the right, perineural inflammation will be there. You can look at the muscle whether there is any damage there. So look at the associated findings also to be able to get to a diagnosis or either have a preference of what diagnosis it can be. Fungal infections, look for vasculitis and those things. And giant cells and granulomas, never miss looking at the magnifications and look at all the sections in the slide. And in the context of a lymph node, just don't end your search for the diagnosis if you see a granuloma, right? Many times neoplastic conditions in lymph node can also have granulomatous inflammation coexisting with it, right? Hodgkin's lymphoma, if you don't look at the background cells and just call it a granulomatous lymphadenitis, you'll miss out a lot of RS cells in the background, right? So that is also important. Don't just stop with one diagnosis, look at all the components. Now the last case, who wants to take this? Done with Ashita, Jayant, Abhinaya, Anuja, is there? Okay. Anybody who wants to present this? This is a short case, so I have mainly 1 or 2 points to make.
Sir, can I?
Sure. Tanay, you could, but your voice is really breaking up, so it'll be tough. You can.
Sir, can I describe it?
Sure. Who was that? Preeti, is it?
Yes, sir.
Yeah, Preeti, you can go ahead.
Sir, because of that network, my video is lost, I think.
Okay, no problem, but we can still hear you pretty well, so we can describe this.
As a 10-year male with a nodule on arm, this is excisional biopsy.
Right.
So the microscopic image. So I can't see the microscopic image.
Okay, I have moved the slide. So it's like,
So in the section show, it shows a nodular mass, individual nodules. It is composed of spindle-shaped cells having elongated buccal nuclei.
okay, so at this power, you can essentially see multiple nodules.
Nodular mass.
Okay, so can you see any difference in the cellularity of the nodule? I think Preeti's voice also seems to be breaking up. Anyone else? Is on this power, do you think the or uniformly similar? Right. Okay, so somebody also said there are central hypercellular areas, which is true, but that central area is something else altogether. Okay, so these areas clearly appear different from the periphery, right? Within this module itself, the central areas seem a little bit different compared to the other areas which are bluish in appearance. Okay, at this part, and this particular correct. So that has a myxoid look towards the periphery, whereas central is a little bit different. And this one appears more bluer compared to others. Bluer not due to myxoid, but appears to be more cellular, right? At this part. Otherwise, what is this? What plane of the tissue is it set in? Is it a dermal? Is it a subcutaneous? Is it a deeper tissue?
It's a deeper tissue.
Correct. Right. So it is present in the skeletal muscle plane, right? So either side of the lesion, we can see skeletal muscle fascicles. Okay. Right. And that's a hyper of the same. We can again see the same pattern here, right? The center of the lesion is different compared to the surrounding parts. Same thing which is seen here. So, okay, let's finish the description. What do you think is this image showing? Preeti, how's your connection?
Yes, sir.
Yeah. So what do you think are the findings in this image?
Sir, here we can see a nodule which is composed of a spindle-shaped cells. Sir,
You really see a nodule here? Do you see? Okay, that fine.
so here we can see a unremarked skeletal muscle bundles.
Okay.
Sir, the pointer what pointed it is a nerve.
That one, all right. There seems to be a lag at your end. Okay. But skeletal muscle also, do you think the skeletal muscle bundle as such is normal? You normally see skeletal muscle fibers lying so far apart, singly like this? No, right? So there is some lesion which is spreading apart these individual muscle fibers, right? Still not destroying them altogether. And what do you think of all these pink stuff which is there in the between? Here we are seeing some adipose tissue, we are seeing some blood vessel, and there are a lot of collagenous material with some cells in between, right? What do you think of that?
It's a dark eosinophilic cytoplasm. Mast cell is a possibility.
Yeah, few mast cells are there, but okay, let me go to the highest magna. Okay, and in this nuclei, what do you think?
These are spindle-shaped, elongated nuclei.
Okay.
Wavy.
Right, so wavy with pointed nuclei. Okay,
So elongated buccal nuclei.
correct. Elongated buccal nuclei, I agree with. Okay, so what all does this point to? So let me go to the subs. Right, so that is the diagnosis. Just to summarize the findings, it's a deep location engaged, and the enlarged nodules which you're seeing, those were nerve trunks. Okay, and those central hypercellular areas, those were nothing but the nerve fibers, which were the normal component. The myxoid substances all around that, and which is expanding the nerve trunk. And we could see several nerve trunks which have this change, okay, with this myxoid change. And we could also see that spindle cell proliferation both within and outside the nerve trunks. We could see that spindle cell proliferation was infiltrating the adipose tissue, the skeletal muscles, separating out the skeletal muscle fibers. Right, focally there was hypercellularity, but there was no nuclear activity, mitotic activity. So all this put together points to a diagnosis of sexiform neurofibroma. Right. And here the only point I want to make is that there are a lot of genetic tumor syndromes now. Okay, and this is a review article which was the seminars of diagnostic pathology, right? 2018. What is the role a surgical pathologist can play in uncovering these hereditary tumor syndromes? Okay, it has been said that at least 10% of all myeloneoplastic diseases have a hereditary predisposition. Okay, and what leads you to suspect a hereditary cancer predisposition? There can be several things. As a pathologist, you can look at cases which have unexpected early onset. You can look at unexpected sites which have these kind of lesions, especially neurofibroma in the viscera, leiomyosarcoma in the stomach. Okay, can be abnormal histological pattern. Like in this case, it's a plexiform neurofibroma. Okay, similarly, some abnormal precursor lesions if you see is closely associated with predisposition syndromes like C-cell hyperplasia, Cajal cell hyperplasia, and GIST syndrome. So at the back of your mind, you remember this, right? So if you encounter this kind of case, you can advise further workup, right? Each syndrome has its own diagnostic criteria. Many of them are clinical, some of them are mutational. So not everything you can decide with a microscope, right? But you should be aware enough to recognize and alert so as to guide the further diagnosis in these cases, right? So any questions so far? Otherwise, we are done with the session. So it's a long one, but I thank the students for being active and participating so far. So if you have any questions, I'm happy to discuss. Dr. Kurat and Sheetal, any questions which I have left out from the audience?
Yes. So I think you
sir-
addressed all of them by
There's one question I think which was there. It says which spatial stain has been used for chromoblastomycosis.
Special stain, I haven't really shown you any special stain here. Special stains are the usual ones. You can do RSD and GMS. This is just a H&E image, right? And mostly even in these cases, the pigment you can really see in the H&E stain. It's a kind of myelin pigment which is there in this fungi. That's why they appear brown, right? So these usually find out. My intention of showing this hair follicle side by side was, in some cases there can be there are certain diseases where the hair follicles can rupture and the hair shafts can be present in the tissue, right? Many times they can also incite a very strong inflammatory reaction. So you should be able to differentiate a hair shaft from one of these chromoblastomycosis kind of fungi. Right? That was my intention of showing this side by side. Otherwise, it's clearly a hair follicle here. Okay. Any other questions?
No, I think everything is answered.
Okay, I'll stop sharing the screen now.
I think Prashant and Nirotpal, I must congratulate you. An excellent session of marathon session actually. It's 9:30.
Yeah.
And there are still 100 of us sitting in the room, and they don't want you to leave you and maybe get more tips. I think it's very nicely done. I'm sure Sheetal and Kurat will agree with me.
Yes, sir, definitely.
So there are no.
Even we learned a lot of bits actually, but
Prashant,
definitely no points.
Nirotpal is there.
Nirotpal.
Yes, sir.
I think so.
Nirotpal, do you have any final comments? Yes, sir. Do you have any final comments for the students? You want to tell anything?
No, sir. It's all. It was very, very interesting, actually. Always wanted to do that. I thought I would go more into. It's just not exam, but many things which the residents won't know, the postgraduates won't know, and they don't think like. And Prashant wanted it to be exam oriented. Okay, just like that.
Just wanted to speak to the
Oh
time.
no! Oh, I think maybe my voice
I think it was
was.
balanced.
Right. I think in any case, the best way to prepare for an exam is be thorough in your routine cases, what you see. That is where you get to pick up all these. When you see all these being done in life, identifying a mismatch, a mislabel, right? Mislabeled IHC case, for example, or a false negative or false positive case, those things stay with you. Right? Exam preparation doesn't mean that you go and sit and see very rare cases which have been collected over years by somebody. Right? More important is to learn these kind of things which you generally tend to miss out. How to look at all the sections, how to be consistently follow a pattern of diagnosis and interpretation. That is what helps more in an exam, right? Other than seeing hundreds of rare cases. That is what in the conclusion I get to say. That's all.
I mean, students, do you have anything to ask teachers now, or you're tired and want to go for dinner now? We kept you away from your meal, all of you. If there are no comments, Kurat and Sheetal, do you have any comments for?
No, sir.
But I think,
No, sir. I think
Thank you.
the session
Yeah, beautiful.
ends.
Yes.
I'll speak, sir. I think wonderful lectures. Both of the cases, both of them have presented very good cases. And thank you, students, also for actively participating. Thank you, Kurat, for